Bismillahir Rahmanir Rahim. Welcome fourth year EMP students. This is my second recorded lecture prepared and presented by me, Dr. Khalid Diab. I am an OB/GYN professor at Ain Shams University. Hope you find it useful and helpful. I will share with you the following slides that will review basic clinical management of preterm labor or preterm birth. By the end of this presentation, the student should clearly understand the following ILOs. The presentation will follow through the following heading titles: the condition, which is preterm labor or preterm birth, its causes, its complication, and its three main clinical presentation, either at-risk women for preterm birth, or threatened preterm labor, or established preterm labor. For each presentation, clinical management will be discussed, notably evaluation and treatment. Preterm birth is defined as expulsion or attempt of expulsion of the product of conception after the age of viability, which varies between countries between 20 to 24 weeks and before 36 weeks plus 6 days. It may or may not be preceded by uterine contractions. WHO further subclassified preterm labor into late, moderate, very and extreme preterm labor as shown in the table. It is noted that all preterm birth, mainly late preterm birth, represent 7 to 12% of all birth. The increase of prevalence of preterm birth in the 19th is related in part to the increase in multiple gestation. Almost 1/3 of preterm birth are elective, not preceded by labor, due to maternal or fetal or neonatal indications. Most important are hypertensive disorders, antepartum hemorrhage, and fetal growth restriction. On the other hand, spontaneous preterm labor represent the majority of preterm birth. 30% are accompanied by preterm, pre-labor rupture of membranes, 10% accompanied by multiple pregnancies. In this presentation and for clinical management, spontaneous preterm labor will be subclassified into those with or without significant maternal or fetal pathology as shown in the following slides. Note that those with significant maternal or fetal pathology are similar to those elective indications if preterm labor did not start spontaneously. The following table shows proportions of preterm birth by etiology. Four discrete mechanisms are involved in the pathogenesis of spontaneous preterm labor as shown in table. Although each mechanism has its distinct epidemiological, genetic, and clinical characteristic, yet they all share a common final pathway. That's to say, a formation of uterotonic agent that leads to stimulation of uterine contraction prematurely. Preterm birth has multifactorial interaction as shown in the following figure. To simplify the etiology of spontaneous preterm labor, 1/3 are idiopathic, 1/3 are associated with preterm pre-labor rupture of membranes, and the remaining is related to uterine, extrauterine factors, and to cervical insufficiency. Although preterm birth represents about 10% of all births, yet it accounts for 50 to 70% of perinatal morbidity and mortality. Failure to further lower preterm birth rate is one main cause for inability to further lower perinatal morbidity and mortality. Perinatal morbidity and mortality are mainly inversely related to the gestational age. The main short-term morbidity are RDS, kernicterus, necrotizing enterocolitis, metabolic changes. Long-term morbidity is mainly cerebral palsy. Rarely maternal morbidity do occur apart from psychological and financial impact and the risk of recurrence. One study showed later increase in the cardiovascular morbidity in women with previous preterm birth. Preterm labor may be presented to the OB/GYN physician either as asymptomatic at-risk woman at her preconceptional visit or in her early antenatal visit, or she may present it with classic symptoms as uterine contractions or lower abdominal heaviness, or non-classic, non-specific symptoms as backache or excessive vaginal discharge during her antenatal care. Symptomatic preterm labor are further subdivided into either threatened or established preterm labor. Needless to say that several maternal or fetal indications may require indicated preterm birth. Shown in this table, various risk factors that are implicated in the etiology of spontaneous preterm labor, subcategorized as history is taken. The student should recognize which is modifiable and which is not modifiable. Furthermore, he or she should know how to ask about these conditions in the previous and current pregnancy. Previous preterm labor is the most important risk factor for repeated preterm birth. Shown in the following table, recurrent risk in the second pregnancy. Also shown how the risk is markedly increased in the third pregnancy. Also shown in the following slide, risk factors as taken during the current pregnancy. Try to identify those modifiable risks. Discussion will be done in the face-to-face session. Infection as a risk factor for preterm labor is shown in the following table. Transvaginal cervical length measurements between 14 and 24 weeks is now considered the basic clinical practice to identify women at risk for preterm labor. Values of transvaginal cervical length of 25 mm is taken as the limit to give prophylactic therapy to minimize risk of preterm labor. Also shown in the following table, the relative risk of preterm labor as a function of cervical length. In summary to previous slides, preterm birth may be presented as asymptomatic at-risk women or symptomatic. Asymptomatic at-risk factors for preterm birth may be identified during women evaluation, during history taking for demographic data, past medical history, obstetric and menstrual history in the setting of preconceptional care. The most important factor is an unexplained previous history of preterm labor, pre-labor rupture of membranes, or mitral pregnancy loss. During pregnancy, added risk factors to be identified are factors in the current pregnancy, as early threatened abortion and evaluating transvaginal cervical length measurements between 14 and 24 weeks, and optionally assessment of cervicovaginal fetal fibronectin level. The student is encouraged to take history relevant to assess risk factors related to preterm birth from every woman, either preconception or during her antenatal care. Note, risks may be modifiable, whereby women is counseled to avoid it, or non-modifiable. Furthermore, risk identification will be only of value if there is proven intervention that it prevent preterm labor. More discussion will follow in the face-to-face session. As stated in previous slide, all women preconceptional or during early antenatal visits, should be evaluated for risk factors for preterm birth. Those at risk should be supplied with information and supportive care and should be counseled for interventions to prevent or minimize the risk of preterm birth. Needless to say, once pregnant, all women should have an early confirmation of her expected date of confinement to help in further management. The most important relevant risk factors for preterm birth are past history of previous preterm birth, pre-labor rupture of membranes, mid-trimesteric pregnancy loss, and any obstetric history suggestive of cervical insufficiency, and a short transvaginal cervical length between 14 and 24 weeks, and also early detection and treatment for any related medical or fetal conditions that may be implicated with induced preterm birth. The diagnosis of short cervix is defined by a cervical length, transvaginal cervical length, less than 25 mm between 14 and 24 weeks of gestation. Transvaginal sonography is preferred. However, in patients with a well-imaged cervical length more than 20 mm on transabdominal sonography, transvaginal may be avoided. Cervical length measurements is an insensitive screening test for prediction of preterm birth in multiple gestations, and no intervention has been proven beneficial in preventing preterm birth in this population with short cervical length. For these reasons, we suggest not performing cervical length screening in this population. The evidence-based interventions to minimize preterm birth is written in red fonts. As regards pharmacological intervention to prevent preterm labor in asymptomatic at-risk women, no role for long-term maintenance tocolysis or prophylactic antibiotic to minimize the risk of preterm labor, yet the presence of cervicovaginal infection or urinary tract infection should be therapeutically treated. Low-dose aspirin is of value for prevention of maternal hypertension and fetal growth disorders in related cases. Progesterone supplementation has proven reduced risk for preterm birth by 1/3 in women with previous preterm birth and a short cervix as diagnosed by transvaginal sonography. Progesterone supplementation proven no value in the setting of pre-labor rupture of membranes or after an episode of threatened preterm labor, and is of limited value for multiple pregnancy. Few or minimal complications or contraindications are observed for progesterone supplementation to prevent preterm birth. Clinical forms and dosage of progesterone is given in the following table. As regards surgical intervention for prevention of preterm birth in asymptomatic at-risk women, this will depend on diagnosis of cervical insufficiency, previously known as cervical incompetence, which is a presumed physical weakness of the cervical tissue that results in early preterm labor or mid-trimesteric pregnancy loss. Cervical insufficiency is diagnosed either by classic history, the painless, recurrent, more than 3 or equal to 3 preterm labors, spontaneous preterm labor or mid-trimesteric pregnancy loss, preceded by cervical dilatation, and whereby other causes are excluded. This is a history-based diagnosis. Ultrasound-based diagnosis of cervical insufficiency is characterized by a short cervix on transvaginal sonography before 24 weeks below 25 mm. Physical examination-based diagnosis is by confirming advanced cervical dilatation before 24 weeks. Cerclage may be done for any of these indications. It is performed mainly vaginally, rarely abdominal. The student is encouraged to read about the procedure. Further discussion will be in the face-to-face session.